Hello, everyone. Thank you for joining us today and welcome to this Heart and Stroke webinar, Optimizing Rehabilitation and Recovery Following Stroke. Today's session will focus on the 7th edition of the Canadian Stroke Best Practice Recommendations, specifically the Rehabilitation, Recovery, and Community Participation Following Stroke 2025 module update. My name is Chelsea Martin, and I'm the project lead for Stroke Best Practices here at Heart and Stroke, and I will be your moderator for today's webinar. So before we get started, just a few quick housekeeping items. You'll be connected to today's webinar through your computer audio by default. If you prefer to listen by phone instead, you can select phone call or call me and follow the prompts to choose the option that works best for you. Questions are welcome during today's webinar. Please feel free to enter them through the question panel, and we'll do our best to address these questions during our Q&A period at the end of the webinar. Today's webinar will be recorded and available on Heart and Stroke's YouTube channel, as well as on the Canadian Stroke Best Practices website. Due to some weather events today, there's a chance that one of our webinar hosts may be disconnected. If this should happen, please stay on the call and we'll resume the webinar momentarily. I would like to begin by acknowledging the Indigenous peoples of all the lands that we are on today. While we meet today on a virtual platform, I would like to take a moment to acknowledge the importance of the land, which we all call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. From coast to coast to coast, we acknowledge the ancestral and unceded territory of all of the Inuit, Métis, and First Nation people that call these lands home. So our webinar today will focus on the following learning objectives, which will include to discuss highlights from the 7th edition Rehabilitation, Recovery, and Community Participation Following Stroke module update, to review and describe the current evidence on select stroke rehabilitation recovery topics, emphasizing best practices and implications for practice. Our learning objectives will also include to reflect on the personal perspectives through the journey of stroke rehabilitation recovery from the lens of a person with lived experience, exploring tips and strategies to support meaningful recovery and participation. I have the honor to welcome our presenters today, and I invite you to come on camera. Our first presenter is Dr. Nancy Salbach. Dr. Nancy Salbach is a physical therapist and professor in the Department of Physical Therapy at the University of Toronto and Kite Senior Scientist at the University Health Network. Her research at the Toronto Rehabilitation Institute Chair at the University of Toronto aims to optimize mobility and exercise participation post-stroke. Dr. Salbach is a leader in setting policy and clinical practice standards for stroke rehabilitation in Canada and internationally. Another presenter is Dr. Jennifer Yao. Dr. Jennifer Yao is a clinical associate professor and head of the Division of Physical Medicine and Rehabilitation at the University of British Columbia. She's an active staff physiatrist, consultant, and previous medical site lead at GF Strong Rehabilitation Center in Vancouver. She has worked as a physiatrist and medical leader in the field of brain injury and stroke rehabilitation for over 20 years. She actively participates in community-based, regional, and provincial initiatives that provide education and advocacy for people living with stroke. Our next presenter is Janice. Janice is a person with lived experience of stroke and is a retired business analyst with over 20 years experience in the non-for-profit sector, including 9 years with the Heart and Stroke Foundation on the development side. She holds a BA and an MBA. In retirement, she has chosen to continue to do the work she has done throughout her career, but now on a volunteer basis. More importantly, she is a wife and a very proud mom and grandmother. And our next presenter today is Dr. Michelle Nelson. Dr. Michelle Nelson is a full professor at the University of Ottawa and a senior investigator at the Bruyere Health Research Institute, specializing in implementation science and integrated care. She leads the Care in Common Living Lab, serves as vice president of the World Stroke Organization, and joint editor-in-chief of the International Journal of Integrated Care. Her work focuses on bridging clinical and community systems to advance health equity and improve care transitions for people living with stroke and complex chronic conditions. Disclosures of our presenters are listed on this slide. Before we continue, we'd like to just take a moment to acknowledge and thank the many people who contributed to the update of this module. The development of evidence-based guidelines requires an incredible amount of time, expertise, and collaboration. We want to offer a special thank you to Nancy Salback and Jennifer Yao, our co-chairs, for their astounding leadership, dedication, and guidance throughout the update of this module. We'd like to sincerely thank Patrice Lindsay, the senior editor, and Michelle Nelson and Jinx Shi, the Part 1 co-leads, for their critical contributions to this work, as well as the stroke advisory leadership who also supported this update. We want to acknowledge and thank the writing group for their expertise and commitment throughout the module update process. And finally, our sincere thanks to the Community Consultation and Review Panel for sharing their perspectives and helping to ensure that this work is grounded in real-life experience. I'll very briefly walk us through today's agenda. We'll begin by hearing from Janice, who will share her insights and perspectives shaped by her personal journey through stroke rehabilitation and recovery. Next, we'll discuss some of the overall changes across all three parts of the updated rehabilitation, recovery, and community participation following stroke module. We'll then move to explore select key updates and points through Part 1, Part 2, and Part 3 of the updated module. And finally, we'll then conclude today's session with a panel discussion and Q&A. To begin our webinar today, I'm very pleased to welcome Janice. Janice, thank you so much for being here and for generously sharing your experience with us. I'll turn it over to you.
Thank you, Chelsea. My goal in sharing this part of my story today is not to elicit the woe is me reaction, but rather to give you some context as to where I started my stroke journey and how I progressed forward. In 2022, I had a hemorrhagic stroke. I was getting ready for my day when I felt my legs give out from under me. I made my way to my bed and I called for help. The next thing I remember was waking up in ICU with everything that stroke has to offer being thrown at me. I had an emergency craniectomy. I was shocked to learn that there was such a thing as a skull blank. I had hallucinations, left side paralysis, loss of vision in my upper and lower quadrants, left side visual field, loss of choking reflex, hence a G-tube was inserted, inaudible speech due to immobile vocal cords. And just an FYI, the voice you're hearing today is just plain old, has nothing to do with my immobile vocal cord. I had post-stroke seizures and PTSD. But the kicker in all of this is it happened 14 days prior to my daughter's wedding, which had in fact been canceled twice previously because of COVID. Over a period of, 5 or plus months, I received a variety of stellar professional support on my stroke journey. While in hospital, I received PT and RD. When inpatient rehab facility was PT, OT, SLP, and RD. And once I was at home, I received virtual support for PT, SLP, and psychiatric support. Now, 4 years later, I'm so fortunate to report that I walk unassisted. I ate chocolate and pizza to my heart's content. I joyfully and somewhat gracefully walked down the aisle at my daughter's wedding. And most importantly, probably, I regularly sing and dance with my grandson in my arms until he giggles with glee. Next slide, please. You. My recovery journey was non-linear, very much like the stock market, with highs and lows, but the trajectory was pretty much somewhat in the upward direction. But I never really knew how high the highs were going to be, how lows the lows were going to be, or how long the journey was going to be. So I knew that I had to celebrate all the highs and, push past all the lows. I remember the first time I lifted my hand off the bed, and literally it was probably about an inch. To me, that the joy was like winning the lottery. The first time I made my way to the washroom in hospital using a mobility aid, the feeling was akin to really riding a bicycle for the first time. On the days I could not eat pureed foods without choking or aspirating, when I failed the formal swallowing tests, I just convinced myself that tomorrow was going to be another day, and perhaps I would conquer something, like taking my bra off for the first time. I remember my family was at home eating dinner, and I was so proud of my accomplishment. I literally dangled the bra on screen in front of them while they were dining. Next slide, please. For me, two key components of many helped me propel forward in my journey, in my recovery journey. The first one was setting goals. Obviously, my major goal was to walk down the aisle at my daughter's wedding. And I understood that was going to take uh, stringing together a bunch of small goals to get there. But the key here was that they were my goals. I do recall being in in-house rehab, and I was constantly asked to complete cognitive tests so that I could eventually get my driver's license reinstated. For that time, I could barely eat pureed foods without choking. I could barely really produce any sound with my voice, and still struggling with dressing and things like that. So I eventually declined doing these cognitive tests because driving was so far from a priority for me. The second component that I think is the most key is having positive mental health. That was probably the most difficult and most vital battle in my effort to uh, in my effort. Surprisingly, it was the physical fatigue. It was not the physical fatigue, but the emotional effort it took to stay hopeful despite all the changes and still trying to be me. Here I'm going to jump on my little bandwagon and talk about medical jargon. Being from a medically focused family, I truly do appreciate how important, concise, coherent communication amongst medical professionals is. But I believe it should be patient-centric when standing in front of the patient. And I'll give you some examples. And really what I'm talking about is positive terminology. Visual defect versus change in vision. When I was first diagnosed with, when I was first told as a child that I need glasses to see, I wasn't told I had a visual defect. I was in essence just told I need glasses, and here you go. Yet, in my current stroke situation, I was labeled as someone having had a visual defect. I don't have a visual defect. I have a change in vision. And I being labeled that way really did impact me mentally. Same goes for the concept or the verbiage of cognitive impairment versus change in cognition. They're very different. One, again, has a negative connotation. The other one just means it's different, and probably I need to change in what I do. Again, same vein, I won't belabor it. I'm sure you've all heard this before, but the terminology rehab versus recovery. One has a negative connotation to me. The other one is very, very positive. Excuse me. The the last issue around mental health is something I call testing fatigue. I, fully understand that it's important to objectively to monitor progress so that the appropriate recommendations can be made. But from multiple MRIs and scans and scopes and swelling tests in hospital to measuring how quickly I can walk from position A to position B, how many times I could stand up from a sitting position to a standing position, or stand and count a stand with maintaining my balance. This is as to counting how many pictures of dogs and cats and chairs I can recognize. I felt test exhaustion on top of the actual exhaustion of having had surgery and a stroke. And all of this made me feel anxious and feared poor results. As a business analyst, I was trained to detect issues and provide recommendations for improvement. Unfortunately, I really have none to offer around test fatigue, as if you can't measure, you can't monitor, and so on and so forth. Just like to thank you for listening to my recovery journey. And I hope the messages shared today are something that can be carried forward into your everyday practice. Thanks again. And I appreciate all the hard work that you allied professionals and medical professionals have done to get me to this point. Thank you very much.
Janice, thank you so much for sharing your journey with us today. Your insights provide a powerful reminder of the real-world impact of stroke rehabilitation and recovery and why this work matters so deeply. Thank you. This slide highlights some of the overall changes across the updated Rehabilitation, Recovery, and Community Participation Following Stroke module. One of the most significant changes is the reorganization of the content to align with the ICF framework, where ICF is the International Classification of Functioning, Disability, and Health. The module is now organized in 3 parts, and across all 3 parts, grade ratings have been applied to each recommendation. The grade rating has 2 components: the strength of the recommendation and the quality of evidence. The strength of the recommendation is either strong or conditional, and it's based on the balance of desirable and undesirable consequences, the quality of evidence, values and preferences, and resource use. The quality of evidence, which is the second part, is either high, moderate, or low. For more information on guideline development methodology, please visit the Stroke Best Practice website. Now, we recognize that this module covers a large volume of content and a wide range of topics, reflecting the breadth of stroke rehabilitation across the care continuum. In this webinar, we will highlight 5 key updates or points in part 1, 2, and 3, but this is really just a snapshot. We strongly encourage you to explore the full module, where you'll find the complete set of recommendations, evidence tables, and important context. I'll now hand things over to Michelle, who will walk us through part 1. Next slide.
Thanks so much, Nancy. Hi, everyone. Welcome. So I have the pleasure of talking about part 1, which focuses on the planning and organizing of stroke rehab delivery. The updated module provides evidence guidance on everything from initial assessments to early supported discharge criteria. So let's get started. The module is organized into 9 sections that really create a comprehensive framework for planning stroke rehabilitation. Sections 1, 2, 3 establish the foundation, talk about initial screening and assessment, stroke rehab unit standards, inpatient delivery, including timing and intensity. Sections 4, 5, and 6 expand beyond the hospital, talking about outpatient and community-based rehab, long-term care settings, and virtual rehab, which is new in this edition. Section 789 focus on the human elements. So the idea of this interdisciplinary care planning, transitions, supporting stroke survivors and their families, and education throughout the rehab journey. So together, these 9 sections provide a complete roadmap for organizing stroke rehab that optimizes outcomes. Next slide, please. So what's new? The update, the very first thing I wanted to highlight was that the update reflects the reality of modern care. And as many of us know, 80% of people who have a stroke have an average of 5 other comorbid conditions or medical conditions. And it's important that we think about that we can't separate stroke rehab from overall medical management. And so this edition expands the considerations of rehab to think about those who have expertise in managing ongoing medical comorbidities and other complex medical needs. So you'll note that we've added a clinical consideration specific to incorporating professionals who can actively manage issues like diabetes, heart failure, and other chronic diseases while rehab is ongoing. We're not talking about consultations. We're talking about integrated medical management as part of a rehab team. So this clinical consideration really acknowledges that successful rehab requires medical stability and the ongoing management of conditions, and that we should include the healthcare professionals who are supporting the medical management in that regard. Thank you. So a key update in this in this edition is the emphasis on equivalent rehabilitation intensity regardless of setting. The strong recommendation backed by high quality evidence is that people with stroke should be admitted to specialized stroke rehab units. However, the writing group recognized that that's not always possible, and that when people who've had a stroke are treated on general rehabilitation units, they should receive the same intensity and principles of care as they would on a dedicated stroke unit. And the key recommendations and considerations are in the full module. Now, there is a critical safety message here. We know that stroke rehabilitation as early as possible should be started, but, and this is based on high quality evidence from the AVERT trial, that do not provide very early high intensity mobilization within the first 24 hours. What else is new? Another important update in this edition is the enhanced focus on family and caregiver involvement in the rehab process. The edition includes new recommendations on family meetings, the inclusion of virtual modalities to support family participation, particularly when families are unable to be physically present. 2 key sections drive this message home. Section 9 identifies the importance of encouraging families to attend therapy with consent, learning actual rehab and recovery skills that they may need to support safety and self-management of their family members at home. And we really emphasize that this moves families from passive observers of rehab to active participants in the recovery process. Section 8 recognizes that support should be comprehensive and continuous. Families, as we know, need psychosocial support, education, skills training, and information about community resources. We emphasize that this isn't a one-time conversation. It is, in fact, support that should occur through all transitions of care. Increased focus on community engagement. So we wanted to recognize that rehab doesn't end when someone leaves the hospital, as we're all aware, and the recommendations now explicitly identify and focus on strategies for community participation and engagement in community activities as a part of returning to meaningful life roles. This is a fundamental shift aligned with the ICF from moving from recovery to meaningful participation. You'll see Section 8 talks about how this is operationalized by requiring that individuals receive, so people who've had a stroke, family caregivers, receive information about peer support groups and community services. And we're actually encouraging not a list, but an actual description of services, what they offer, and really active encouragement to participate. And finally, one of the key points in this update is the explicit acknowledgement of outpatient and community-based rehab with inpatient standards. And what we've suggested in the recommendations is that outpatient and in-home rehab should include the same core elements as inpatient care. So what does that mean practically? Again, first, that families and caregivers remain active participants in the recovery process. There's goal-setting, transition planning, not just during hospitalization. An interdisciplinary team approach continues with regular team meetings and communication to discuss clients, review progress, and plan transitions. Third, and this is specific, that therapy should be 60 minutes per session per required discipline, provided 2 to 5 days a week. So this gives outpatient programs or rehab programs a concrete benchmark for intensity. So that is a quick overview of part one. Again, echoing Nancy's comments, please review the full module. There's much more detail in the recommendations there. I'm going to pass back to Nancy, and thanks so much.
Thank you, Michelle. It's my pleasure to present an overview of part 2 of the guideline, which focuses on the delivery of stroke rehabilitation to optimize functional recovery. Next slide. So part 2 includes 10 sections with recommendations on components of stroke rehabilitation delivery that are relevant to multiple health professional groups. You can see that some of these sections are slightly reorganized, and there are some new sections that I'll highlight. Next slide. The key practice messages of part 2 include assess early and assess often by conducting screening and comprehensive assessment as needed, that intensity and stroke and task-specific rehabilitation matter, given the high quality of evidence for this approach in multiple areas. Adjunct treatments have been refined in part 2, and non-invasive brain stimulation remains a clinical consideration as it is not yet available or approved in Canada. And finally, targeted individualized management is preferred. Next slide. We chose to highlight key practices in these sections that are relevant to multiple professional groups. Next slide. In section 1 on upper extremity function, general principles and therapies, bilateral upper extremity training is now strongly recommended as a standalone therapy with moderate to high quality of evidence. Trunk restraint is now strongly recommended with a high quality of evidence. To implement trunk restraint, clinicians have to review the protocol, obtain the appropriate chair, pelvic, or trunk belt, and reaching targets to place on a table or board in front of the patient. Next slide. In section 2 on shoulder pain and complex regional pain syndrome, use of shoulder orthoses to reduce shoulder subluxation in the flaccid stage is a new strong recommendation with a moderate quality of evidence. Shockwave therapy to reduce hemiplegic shoulder pain is a new strong recommendation with a moderate quality of evidence. Although shockwave machines are expensive, they may be available in outpatient departments. Next slide. In section 4 on lower extremity balance, mobility, and aerobic training, for the first time, task-specific training in a group setting is strongly recommended in addition to individual task-specific training. Aquatic therapy and aerobic training are now supported with high quality of evidence to improve multiple outcomes. Although implementing these complex treatments can be challenging, there are toolkits freely online that can help. For example, the START toolkit, led by Liz Innes and Ada Tang, available on the University Health Network website, can support implementation of aerobic training. The START toolkit, there's 2 R's, led by Andressa Marinho Buzelli, available on the Sunnybrook Health Sciences Center website, can support implementation of aquatic therapy. Next slide. In section 6 on swallowing, nutrition, and oral care, there is a new section on oral health with 3 strong recommendations: to deliver active oral hygiene interventions, interdisciplinary education and training, and referral to experts as needed. Next slide. Finally, section 10 is a new section on bladder and bowel function with recommendations related to screening, assessment, and management of urinary incontinence and retention, and fecal incontinence and constipation. Management of bladder function includes a strong recommendation against the routine use of indwelling urinary catheters and a strong recommendation to use TENS to reduce urinary incontinence. Next slide. Management of bowel function includes strong recommendations to deliver an education and behavioral program to reduce constipation and to increase frequency of bowel movements. I'll now hand things over to Jennifer, who will walk us through part 3.
Thank you very much, Nancy. So part 3 is about optimizing activity and community participation after stroke. Next slide, please. There are 5 sections in this part, and the previous mood and depression section was in another separate module that was first published in 2020. And with this version, we've been able to bring it into the overall guidelines under part 3. Similarly, for the cognitive rehab section, there is now a separate module that is being developed for vascular cognitive impairment, and so that is going to be outside of this particular set of guidelines. So part 3 is really all about community reintegration, and we really tried to take a holistic view of individual health complexities. We know that individuals with stroke often have other health comorbidities that need to be considered in the context of their overall rehab plan. There is accumulating evidence on the value of specific interventions, such as exercise, that are beneficial for the management of mood, fatigue, and cognition. Throughout this module, there are strong recommendations to serve as system drivers to promote access to community rehab resources that facilitate reintegration along the whole journey of recovery. Next slide. In terms of section 1 on mood and depression, there is now accumulating evidence for a variety of psychological approaches to management of post-stroke depression. And these are now should be considered first line. There's good evidence for CBT or cognitive behavior therapy, but there are other psychological therapy approaches that are also showing effectiveness. Exercise at least 3 times a week is clearly supported by evidence to help with mild and moderate depressive symptoms, and this is an effect that is separate from pharmacological or medication interventions. Psychological interventions can also be used prophylactically. That means to prevent the onset of post-stroke depression. This is a strong incentive for our health systems to look at funding psychological treatments as part of stroke rehabilitation. Next slide. In the mood and depression section, we now have a particular recommendation that deals with pseudobulbar affect. There's more accumulated evidence now to warrant this recommendation. SSRIs, or serotonin reuptake inhibitors, which are common antidepressants, have demonstrated efficacy in treating this condition, but there are also non-pharmacological interventions that have been studied. Unfortunately, these have not yet been able to demonstrate a positive effect. Next slide. In section 2 on sleep health and fatigue, this is now a section on its own in the 7th edition of the guidelines. Screening for sleep disordered breathing should be a routine practice, as this is a common finding, and when we treat it appropriately, it can result in benefits and better outcome for the patient. Those who are suspected to have sleep apnea should be referred for specialized assessments, as improvement in their sleep can positively impact other aspects of stroke rehab. Next slide. Section 3 deals with cognitive rehab. There is now greater emphasis on the involvement of patients with their families as well as caregivers in the development of the cognitive rehab plan. There's good evidence for use of both general strategies as well as very specific interventions to address these cognitive impairments. In Section 5, we have participation in social and leisure activities. We have separated this out because not only is there increasing evidence in this area, but also recognizing the importance of having social and leisure activities post-stroke. There's building evidence and support to refer to community-based rehab resources for social, intellectual, emotional, and spiritual needs. There's also greater emphasis on addressing issues with regards to sexuality and relationships, and advocacy to have these resources available to those who wish to engage in this discussion at any point in time after their stroke. Next slide. So now you've heard a lot about some of the things that are being recommended. What about things that we should probably look at stopped doing? So there are a few things that have come out in this edition to highlight that. So firstly, in part 2, section 3 on range of motion and post-stroke spasticity, we now recognize that oral medications for post-stroke spasticity can have significant side effects for patients. And that really is what made it less desirable than something that is more focal treatments. So focal interventions are now preferred as first-line interventions. Medications can still be used, but more as an adjunct. There's also stronger evidence now against the use of antidepressants to treat fatigue for those without comorbid depression or anxiety. So in other words, we now feel that post-stroke fatigue is something that is somewhat separate from depression and should be treated on its own. It doesn't always concurrently exist with depression. So we really should be looking at strategies to treat fatigue rather than targeting depression if it's not there. So with that, I'm going to hand you back to our moderator for some summary and conclusions, followed by Q&A.
Thank you very much, Jennifer. So while we've provided a highlight of key points and updates from the 7th edition Rehabilitation, Recovery, and Community Participation Following Stroke module, we recognize this webinar only scratches the surface of what's included in the full module. We strongly encourage you to explore the full recommendations and supporting materials on the Canadian Stroke Best Practice website and/or the published manuscripts available in the American Journal of Physical Medicine and Rehabilitation. If you have more questions after today's presentation, please feel free to reach out to us at the Stroke Best Practices email inbox. Additionally, we plan to host another webinar in recognition of Stroke Month. So if there are any specific topics you would like explored in more detail, please feel free to share your suggestions via the chat or in the post-webinar evaluation. And with that, we've reached the Q&A portion of our session, and I'll invite our presenters to come on camera. Remind everyone to please use the Q&A box to submit your questions, and we'll do our best to address as many as we can during the remainder of the session. So the first question here, I may pose it to you, Jennifer. However, I would be happy to hear from our other speakers as well for any insights you have. What are 1 or 2 practical first steps you suggest for teams looking to implement these recommendations?
Yes, so I think it's important to recognize that these are guidelines and recommendations and not necessarily standards of practice. These are sometimes aspirational guidelines, and I know that resources are hard to come by in our current healthcare system. But I think that it's imperative on every stroke team out there, acute or rehab, to really look at ways of continuous quality improvement and using these guidelines to help with that work. So identifying areas where you think you may not yet be meeting guidelines, and that can be addressed through your operations and through your facilities. And really look at targeting these things in small steps. And over time, that will translate into greater access to guideline compliant practices.
Thank you very much, Jennifer. Anything else to share, perhaps from our other presenters before I move on to the next question?
Chelsea, just wanted to add that I really liked how Jennifer placed the guidelines in a quality improvement framework, and that really you have to be aware of what are your current practices, and then what are the practices recommended in the guideline, and you have to come together, as a team, as a healthcare team, and have meetings and review this information and take an appraisal of your resources and decide which of the recommendations are strong and have a high quality of evidence that you might be able to consider implementing. Thanks, Chelsea.
Well said, Nancy. Thank you. Our next question here is for Janice. Janice, you mentioned that you experienced both in-person as well as virtual rehabilitation during your recovery. Can you share perhaps how each approach may have supported you at different points in your journey?
Sure. Sorry, thank you, Chelsea. It was very interesting because I really wasn't sure that virtual therapy was going to be effective, but in the end, it was it was a necessity because it was still during COVID. But for one, it eliminated the stress of having to travel to receive more therapy. And with the right coaching, I didn't see any much difference between receiving therapy in person compared to virtual. Yes, there were some technological issues you had to make out, but it really got me where I needed to go. Thank you. I'm sorry, but I'm kind of losing my voice here now. Thank you, Chelsea.
Thank you very much, Janice. And I'll build off of that question because we've received a lot of great questions about virtual stroke rehabilitation. So I'll pose this to Michelle, but again, would welcome any of our presenters to chime in. Have you heard of or experienced or seen any great examples of how caregivers and support people have been successfully included in virtual stroke rehabilitation care?
Yeah, that's a great question. And I think there are some really great examples, which I think might make sense for us to collate into an available resource after, because I would hate to highlight one or two. But I do know we had a member on our writing group who had done a trial of including caregivers using virtual communication means. And so thinking about how the work maybe in Kingston could be scaled is an interesting consideration. So yes, there are good examples, but I think this is also an opportunity for us to crowdsource examples that may not have been written up in the evidence so that we can learn from them. One of the challenges of the recommendations and the way that, as we know, guidelines are developed, things need to be published in order to be appraised for level of evidence quality and included in the guidelines, which doesn't always capture what's happening in practice. So I think there's an opportunity there for us to learn from practice as well. Nancy, I see you nodding, and I know you do a lot of virtual work, so maybe you want to comment.
Oh, thanks, Michelle. Yes, in terms of the role of the caregiver or family member or friend in preparing for a virtual session, what we have found in our research that they are so important to assisting with the technology setup, which means, preparing for an encounter using Zoom or MS Teams or whatever the video conferencing software is. preparing the space, making sure the camera's working and the volume, and helping to navigate through the session with these technical or technological issues. In addition, if there's physical movement during the session, if it's whether it be physical therapy, occupational therapy, etc., then the caregiver can also be helpful in clearing the space and making sure that there's a handhold present, and generally supporting the event. But then, of course, being involved to the extent that the patient is accepting of the caregiver being present to learn about the therapy and the recommendations, so that it's more of a family-centered encounter. So I'll stop there, Chelsea.
Thank you very much, Michelle and Nancy, for your thoughtful responses to that question. And I'll turn it back to you, Nancy. So passing the mic to you. We've received a few questions kind of on the similar theme, so I've combined them together. But what does task-specific therapy actually look like in day-to-day? And how do we make sure therapies are applicable to daily life and useful and relevant to people who've experienced a stroke?
Okay, this is a very good question for me because I love task-specific training. So task-specific training, it's also referred to as task-oriented training, it's a goal-oriented approach. And in our guideline recommendations, we describe it as a repetitive, intensive practice of functional tasks, such as walking or answering a phone, tasks that are meaningful to the patient, with the goal of improving performance of those tasks. So that's why it's task-specific training, and these tasks are functional. The tasks should be challenging and also progressively adapted, and involve active participation during the training. And the tasks that you practice will depend on how the stroke has affected you. So it depends on what functional activities you're having difficulty doing and that are a goal of your therapy. So I really appreciated Janice's commentary earlier on about prioritizing your goals. Like, well, what are the main goals for the person who's had a stroke? And then you can involve them in task-oriented training of those activities. So the guideline includes recommendations for supplementary upper extremity training that is task-specific using programs like GRASP, which is Graded Repetitive Arm Supplementary Program. The guideline also recommends group task-specific training to improve balance and mobility. And so that in addition to individual task-specific training of gait. And the guideline also highlights how task-specific training can be combined with other therapies like functional electrical stimulation. And then finally, I just wanted to make the point that even though task-specific gait training and in general training has been described as intensive, we are now seeing this increased focus on task-specific gait training at increasing levels of intensity based on heart rate, which has led to new high-intensity gait training interventions like Walk the Walk, developed by George Hornby and colleagues in the United States, and Walk and Watch, developed by Janice Eng and colleagues in Canada. Thanks, Chelsea.
Thank you very much, Nancy. Our next question, again, I'll pose to Jennifer, but again, if anyone else would like to chime in, please feel free to do so. We've received a lot of questions about post-stroke fatigue. So are there any key messages you'd want people with lived experience and their care teams to understand about recognizing and managing fatigue? And are you aware of any evidence-based assessments to measure fatigue as well?
So I'll tackle the first question perhaps first. Post-stroke fatigue is, as you know, extremely common. In speaking in generalities, it does gradually tend to improve over the course of the following weeks to months, but there is definitely a proportion of individuals who are going to have ongoing, quite debilitating at times, fatigue post-stroke. I think one of the main things initially is to recognize that after a stroke, you are asking your brain to do more with less. So you are going to feel fatigue faster and more frequently. So one of the main things to do initially is to work with your healthcare team and just rule out other potential causes of fatigue. So things like anemia or potentially thyroid issues or other coexisting medical conditions that can be contributing to your fatigue. And also take a look at your medications, make sure that you're taking what you should be taking and that things you may not need that may be contributing for fatigue may be reduced or even possibly discontinued. And then you have to look at your sleep. How well are you sleeping? Good quality sleep overnight is very important for energy during the day. So make sure that you have been screened for sleep disordered breathing at night. And if you have it, that you are seeking some treatment for that. And then just coming to the day-to-day management of fatigue. If you have the opportunity to work with an occupational therapist, they'll be able to provide you with very specific strategies, looking at how you can plan your day, how you can parcel your energy through the day, so to speak, and prioritize things that are important to do earlier in the day when you have usually more energy. And of course, doing practical things like building in rest breaks, looking at distributing really cognitive or physically fatiguing activities throughout the week rather than concentrated into one time. So these are just more practical strategies that can be looked at depending on the situation. So it really does take sort of a multimodal approach to dealing with fatigue. The second question regarding evidence-based measurements of fatigue, yes, there are. There are fatigue scales out there that can be used and are sometimes used, mostly, I think, in research settings. In everyday clinical practice settings, we tend to go by essentially qualitative reports from the patient and or family members. And really, it's only the person that can gauge how tired they are. So sometimes it's good for them to keep a small diary or some notes around what days they felt more tired or what activities might have led up to that, and then trying to find the triggers or the things that contribute most to their fatigue. Um, so we don't necessarily routinely quantitatively measure fatigue, but there are definitely tools out there.
Thank you very much, Jennifer, for walking us through that so clearly. The next question I will pose is to Michelle. We've had a lot of questions related to, I'm just finding the question here, community-based resources. So what role do community-based resources play in long-term recovery, and how can clinicians better connect people to them?
Yeah, thanks. What a great question. So I think I'm going to start my comments by saying that I think we collectively understand that recovery doesn't end at discharge from the rehab program. And as Janice noted, that for many people, the longest, hardest part of recovery happens at home in their communities, often with, less or very little professional support. So community-based organizations, community groups, and peer support fill a really important structural gap that we in the healthcare system were actually never really built to address. What is the now what after rehab? So these organizations and peer support specifically really can address and deliver what we as rehab clinicians often can't provide. Sort of the credible hope, a practical navigation, advice around what has worked in the real world, the idea of role modeling through lived experience. And so the recommendations, the update of the recommendations are really meant to reflect what the evidence is building toward. Now, I do want to emphasize that many of the recommendations are strong recommendations based on lower moderate levels of evidence, but that's because the field is evolving. And so when we think about how we can engage or think about community organizations, I think first and foremost, thinking about them as a partner in the continuum of care, that they are a partner in the support of people post-stroke, knowing what's in our local landscape, knowing what potentially is available to individuals who are returning to their homes and communities, going again back to goals. What are people's goals and how do we support them to access community-based supports and services? Um, and then really actually thinking about what do stroke support organizations, community-based organizations, do that is a unique value add. That it's not simply a referral place, it's actually a partner who can augment and extend. And so I would often ask people, what does a typical Tuesday look like for you? Or what would have a Tuesday looked like for you before you had a stroke? And what of those things do you want to carry forward? And that helped me think about who and what organizations might be available to support people to return back to what was important to them.
Thank you very much, Michelle. Looking at the time, I think we'll conclude here the Q&A portion of the webinar, but we thank you all very much for your thoughtful questions and to our panelists for taking the time to provide their answers as well. So thank you very much. Before we wrap up today, just a reminder that a recording of this webinar will be available online on the Stroke Best Practices website and the Heart and Strokes YouTube channel. After today's webinar, a webinar evaluation will appear on your screen and will also be sent to you by email, inviting you to complete an evaluation. The completion of this evaluation will also automatically provide you with a certificate of participation. We also want to invite you to complete our new Canadian Stroke Best Practices user survey. We want to hear from people who use our guidelines in the Stroke Best Practices website to ensure these recommendations and resources continue to meet your needs and support high quality stroke care across Canada. The survey is anonymous and takes about 5 to 10 minutes to complete. The link and QR code to the survey is available on the screen, as well as in a banner on the Stroke Best Practices website. All of these links will also be provided in the chat. Lastly, Heart and Stroke and the Canadian Stroke Best Practice recommendations have a number of resources and supports related to stroke rehabilitation recovery. Some have been shared here on this slide and will be shared in the chat. But once again, we really encourage you to visit the Stroke Best Practices and Heart and Stroke websites to explore our resources, as there are many others that may be helpful that are not listed on this slide. And with that, this brings us to the end of today's webinar. A big thank you to our presenters for sharing your expertise, insights, and perspectives today. And thank you all so much for joining us to learn more on stroke rehabilitation and recovery in Canada. Thank you very much and have a great day.